Thank you, Tom. It's my pleasure to very briefly introduce Ben Druss. For those of you who are involved, as most of you are, in some aspect of the health profession, we know that health profession means that we hang with our own kind and we don't deal with other kinds. So if we're a medical doctor, we hang with other medical doctors, and as I was told once, a public health doctor is somebody who couldn't succeed as a medical doctor. I was told that by a medical doctor. Ben Druss has made a career out of, in his words, being a mole. He's a trained psychiatrist who went to the public health department at Emory and has been trying to bring public health into, bring mental health, behavioral health into public health, which is a key thing that needs to be done, and breaking down the wall between all the factors that go into poor people hurting in life, whether it's behavioral health or physical health or, frankly, the kinds of services that surround them. So he's particularly focused on people with severe mental illness, but it's that kind of path-breaking, breaking down of professional walls and societal walls that's really what whole health is all about. So we're delighted to have Ben here with us today. Ben?
Hi, everyone. Thank you so much for the kind introduction and for the opportunity to be here at this meeting today. I really believe that the Knowledge Network is a unique organization and that it's really doing what we in the research field need to be able to do more of, which is bridging that gap between science and service, and then from service to science. So what I'm going to try to do today is talk a little bit about specifically this issue of morbidity and mortality, the epidemic of poor health and early death for people with serious mental illness, and a little bit about this kind of crosswalk that's happened over the last 80 years or so between data and practice, and ways in which research has or hasn't had an impact on practice through the years. But let me just start with a story that will maybe capture some of this. A man flying in a hot air balloon realizes that he is lost. He lowers the balloon and spots someone down on the field below. And he says, "Excuse me, can you tell me where I am?" The man below says, "Yes, you're in a hot air balloon about 30 feet above the field." And the man in the balloon says, "Oh, you must be a researcher." And he says, I am. How did you know?" He says, "Everything you told me is technically correct, but it is of no use to anybody." The man below says, "You must be a manager." He says, "I am. How did you know?" He says, "Well, you don't know where you are or where you're going, but you expect me to be able to help. You're in the same position you were before, but now you're blaming me for it." So this is kind of captures some of that tension between these two different worlds, the world of the people who produce the data and then the people who actually have to use it and can use it potentially to improve practice. Okay, so here's the first piece of data. This is from a study that was done around 80 years ago, 1928, by an epidemiologist in New York named Benjamin Malsberg. What it is a study that compared mortality rates between people treated in the state hospitals in New York to the general population adjusted for age and sex. And what you see is that those two top lines for men and women are consistently above those two bottom lines, which are for the general population. Regardless of age or sex, people with psychiatric illnesses treated in the state hospitals in New York were dying about 15 years younger than the general population. So, very important study showing a very big problem, but a problem that as a field we really didn't know what to do with. So what you saw over the coming years was a bunch more studies that consistently showed this problem of excess mortality in people with mental illnesses, serious mental illness. And what you actually saw is that the problem was getting worse over time. So this is a meta-analysis that was published in 2007 that showed that for studies that were published in the 1970s, the excess mortality was a little over 1.5. By the 1980s, the studies were showing a difference of threefold. And then by the 1990s, the gap was getting even bigger. And what this problem reflects is one that you see in general in the disparities literature. It was that the life expectancy for the general population was improving, and groups like people with serious mental illness, disadvantaged groups, were lagging behind. But again, it was still just a statistic, and in fact, where almost all of the research and energy was around this issue was around what are called unnatural causes of mortality. These are things like suicides and accidents. And in fact, there is an enormous risk of excess unnatural deaths related to mental disorders. They're relatively uncommon in the general population, and so you see a huge added risk associated with mental illness. But if you kind of flip the question and look at what, at a population level, are the most important causes of mortality, so you go from basically relative risk to something called population attributable risk, what you see is that the major causes of mortality are the same causes as those seen in the general population, except at higher rates for populations with serious mental illness. So whereas in Benjamin Malzberg's study, those were tuberculosis and syphilis, and to some degree heart disease, now what you're seeing in particular is excess rates of mortality for people due to cardiovascular disease, people with serious mental illness. So really where we moved from data to action on this issue, I believe, was this report that was put together by the medical directors of the National Association of Mental Health Program Directors in 2006. And what was different about this report was it pulled together a lot of the data that was already there, that was already available, including a multi-state study that looked at this problem and that found a 25-year gap in mortality between people treated in the public mental health sector and the general population. But what it was is that we as a field said, we own this problem. This is our problem. And it was important because it was put out by the medical directors, state medical directors, who said, okay, we have to start changing our focus from thinking about treating mental disorders to thinking about treating people with mental disorders. We have to start thinking like public health people about the populations of people in the public mental health sector as the population who we're serving, and we have to think about the whole range of needs and problems that they have. So a very important report. And just highlighting that, if you look at the issue and you really think about who is this population who has the problem of excess mortality, this is a study that we had done comparing the difference in rate of death, years lost of death, between the general population and people with a mental disorder in the general population, and you see about an 8-year gap. But where you see this huge gap is when you start looking at public sector populations, and of course this is who we all work with and are concerned with. And for these populations, mortality is really a common final pathway that represents a combination of risk factors that are the lifetime of living with a mental illness. So what are those risk factors? This is, what I'm about to show you is a chart that's very famous for within the public health world about preventable causes of death in the United States. It was put together by McGinnis and Fahey, published about 20 years ago, and has been updated. And their point in writing the report was that healthcare is important, but it's maybe not as important as we'd like to think it is, as we in the healthcare field would like to think it is. It's maybe 10% of the excess mortality, of preventable mortality in the general population is related to healthcare. A much bigger effect, at least in the general population, is health behaviors. These are issues that are particularly important for populations with serious mental illness who are treated in the public mental health sector. So, for healthcare, as we know, there are gaps in healthcare. Having a mental illness is a risk factor for poor quality of healthcare. For health behaviors, there are elevated risks across mental diagnoses, but extraordinarily high risks for more severe mental diagnoses, for things like smoking, physical activity, lack of physical activity, and poor diet. Genetics is a piece. We were talking, Tom was talking earlier about potentially the importance in the future of being able to understand genetics and as a risk factor both for mental illness and for poor physical health among people with mental illness. And then finally, and what I think is just a hugely important and often underrated factor, particularly for the populations that we are working with, are all those pieces outside of the health system, the social determinants of health and mental health in populations with serious mental illness. So people with mental illness in the public sector are poor, and poor people are at risk, even when they don't have mental illnesses, for excess mortality and poor health. Okay, so yes, as we heard, I'm a psychiatrist, but I sit in a school of public health, so I tend to think about problems from a public health perspective, and for me, this problem of excess mortality in this population is very much a public health problem. So in terms of addressing it, we need to think about different populations, kind of concentric circles, and different types of prevention that we need to be applying across the different populations. So first is primary prevention, and primary prevention means you look across a whole population and think about an intervention that is potentially universally applicable across the whole population. And I'll talk in a minute about an example of one of these and what that would mean for a population of people living with mental illness treated in the public sector. Then you think about identifying higher risk populations, so maybe populations within people with serious mental illness, or people with cardiometabolic risk factors, who you can identify and then get into treatment and try to prevent longer-term development of full-blown disease. And then finally, there's tertiary prevention, which really is just means good treatment. It's taking someone with an illness and trying to prevent the long-term sequelae, disability, and ultimately mortality for people with an illness. So I'm going to give you some examples of these, one of which is a member of the Knowledge Network, which is a program. This is one of the PBHCI grantees. But what they've done in addition to providing medical care is kind of was the initial main goal of the PBHCI program. It was the idea that providing good medical care on-site in community mental health centers would help address these medical problems. But what's innovative about this program is it's also looking at prevention across the whole population, both those with higher risk populations and all those others who are treated at a community mental health center. And this is a program that looks to help engage clients at the Cobb County Community Services Board and the Four Corners Clinic, which is the PBHCI clinic on site at the Cobb County Community Services Board, in eating more healthily and exercising in an on-site gym that's located adjacent to the clinic. So this is primary prevention, right? You're taking a population and doing something that can help prevent the onset of illness. So secondary prevention, again, you know, how do you identify across a population, a high-risk population, and make sure that they're getting the treatment that they need? And I think what's sort of interesting here on the horizon is that the folks who are measuring quality at NCQA, HEDIS measures, are starting to look at these issues of comorbidity in this population. And this is a new set of measures that was developed for HEDIS 2013 that address patients with serious mental illness. And what's interesting is that 3 out of the 4 of these new measures are looking at what kind of medical care they're getting. So diabetes screening for people with schizophrenia or bipolar disorder, for those who have diabetes, diabetes monitoring, and then also cardiovascular monitoring. So, you know, this is critical because, as we all know, you know, you can't improve anything until you start measuring something. And when you start measuring something, especially if you're NCQA, there's the potential for these issues to really start getting serious attention. Okay, so from secondary prevention to tertiary prevention, you know, there's a lot of interest now in health homes, and in particular the concept of behavioral health homes. Behavioral health home is just a health home where the center of gravity is at a community mental health provider. And here I'm just going to talk a little bit about some of our own work, because this has been the focus of our own work, is kind of trying to look at different models of how to do this and study them and see what their impact is on improving the physical health and health care for populations. So there are really 3 approaches to doing this, and I'm going to kind of walk you through, because this has been, for us, a process where we've kind of gradually tried out these different models over time. First is basically co-location, where a community mental health provider does this all on sites. Second is a kind of light version, where you own the problem, but you don't provide all of the medical care, typically through a care manager. And then third, which I'm going to talk about a little bit more because it's a model that there's now a lot of traction in, is a partnership between 2 safety net organizations. So, you know, getting back to this kind of research practice crosswalk, back when I was living in the Northeast, I was a freshly minted researcher at Yale, and the VA got kind of interested in this issue. The VA was concerned about this because, you know, they own both the medical and mental health problems of populations, so of veterans who they serve. So they became interested in this issue around integration, and they started off having a few pilot programs to see whether it would be possible to do a better job around medical management of patients with serious mental disorders, and I was kind of in the right place at the right time, and we were able to do a randomized evaluation of a program that was at the West Haven VA. And the program had a nurse practitioner on site providing the bulk of care. It had a registered nurse who was a case manager, and a family practitioner who basically oversaw the clinic. And what we found was that there was a significant improvement in physical health-related quality of life, not actually mental health-related quality of life in this study, and that it was cost neutral from the VA perspective. So pretty good deal, right? You know, no more expensive, but it improved physical health care. And the VA now has a number of these programs around the country. It's still not the majority, so they still don't typically have co-located programs. It's about 10% of programs nationwide. But there continues to be interest and a push within the VA system in terms of doing a better job of integrating care for patients with serious mental illnesses. So then when I came down to Atlanta, there was a community mental health center that was located at Grady Hospital, and the question was, well, how could you do a program like that here? And doing a fully co-located clinic was prohibitively expensive and so far away from what they were already doing that there was no way we were going to be able to do that. So we said, okay, can we do a more streamlined version? Let's just hire like a nurse like we had in that VA program, or a couple of nurses, and see if we can do a better job of linking patients to get their primary care out in the community. So what we found here was about a doubling in the use of preventive services. And this was by the way, this was an NIMH-funded grant. So it was kind of ultimately a research project, but it was one where we were really kind of wading into this kind of messy public sector clinic to do this work. So we found about a doubling of preventive services use. Clients went from about 20% rates of compliance with like evidence-based preventive services up to something closer to 50%. And actually, in this case, a significant improvement in mental health-related quality of life, so they felt better. And then costs, and this is often what you see in these new programs, is that while in the first year there were startup costs, clinics weren't completely up and running, it was a wash. Case was slightly more expensive than control, people in the P-Care program. By 2 years, you started to actually see some cost benefits. People were using the emergency room less and had less inpatient care. So this is great, right? Well, but the problem with cost studies and with cost effectiveness studies in general is that they're taking kind of a societal perspective. And the way that the health system works is that the people who reap the benefits aren't always the ones who pay for the services. So in this case, really the question was, from a budget perspective, could you afford to pay the nurses to do this based on the revenues that you would be getting? And this clinic had more than 50% were uninsured. So from a budget impact perspective, it was not financially sustainable. So again, here's an example of you have one kind of data that is good and that researchers like, but then kind of the reality in terms of how people are thinking about it. So this is a case where I think thinking about something like cost, not only from a societal perspective, but from a budget impact perspective and understanding what it takes to get a program in place and to have sustainability is really important. Okay, so I just want to briefly mention there are a number of Medicaid state health home state plan amendments. Unfortunately, we don't have one at this point in Georgia, but this is one opportunity to begin to build these health homes for people with serious mental illness. There are, I believe, 12 of them currently that have been established, and the first one, and the one that is probably the best developed, is in Missouri, and it's using a program similar to the approach that we used in that case management study, in which patients in community mental health centers are assigned a case manager who links them out to medical care. So this is something that's important and a chance to really kind of roll these out more broadly at a national level. So finally, we had the opportunity after that, we sort of said, well, what's next? And the problem with this case management program was the care that we could get was only as good as the care that was delivered in the community where we were referring people. So we said, wouldn't it be great if we could get a partnership between a community mental health center and a medical center, like another safety net provider, and see if we could develop a clinic that was like a virtual health home spanning two organizations, that could provide better medical services to patients who were basically shared across the two organizations. And this became the kind of follow-up to that peak care management study, and was the beginning of a really wonderful partnership that we've had and that has existed between a federally qualified health center, West End Medical Center, and then the Cobb County Community Services Board. And the West End Medical Center set up a little satellite clinic inside of the Cobb County Community Services Board. And there were a lot of advantages to this compared to, if you just sort of plopped a nurse practitioner down inside there, they were able to refer patients, more complicated patients, back to the mothership for specialty needs. There were financial benefits because they could bill at more favorable FQHC rates. And in the meantime, soon, just after we had begun that, there was a very important new program, demonstration project that started small, I think 13 grantees, but then rapidly expanded, and this one is already out of date. I think this has 93, but I just heard there's 100 grantees now, which are largely using these partnership-based approaches between safety net providers to try to improve medical care for patients treated in community mental health centers, to build these behavioral health homes. And again, this is RAND, as you may be hearing about later, and Deb Scharf has done a very good evaluation of this, and we'll be able to understand here more about what happens when you try to implement a very ambitious demonstration project across multiple different sites, which, multiple different public mental health sites. Okay, so I've been talking a lot about what happens on the provider side. I want to talk a little bit about the patient side also, because it's something we sometimes forget about on the provider side, that you really can't do quality improvement if patients aren't engaged. Patients are, free-range humans. They spend most of their lives outside of doctors' offices, and particularly for patients with serious mental illness, there's this issue of how do you really engage them in care? How do you activate them? There's a term called activation that's been used in the general medical literature, which basically says, can you self-manage your own illness? Can you be an effective advocate for yourself and communicate in a primary care practice? So we've been doing a project that started off as a pilot project that adapted a medical self-management program for patients with serious mental illness, with the goal of helping them better engage in their care and become better self-managers. And we did find in the pilot study that, in fact, they did get more activated in their care. We're now kind of doing a full multi-site trial of that. And this is a case, actually, where this program, we worked with the Georgia Mental Health Consumer Network and with other consumer advisors, who then kind of took pieces of that program and built that out to a program that is now being used more broadly and has kind of merged the program that had originally been developed at Stanford with peer specialist training, and is really something that now, we can kind of own more as a field. This used to be a supercomputer. I think it was actually the very first supercomputer, the Cray supercomputer, developed in 1964, and it was called a supercomputer because it could process 1 million flops at once, it was a mega flop of information. So anyone have an iPhone on them? So an iPhone 5 can process 32 megaflops of information. And I guess the point here is that where all these other things that I've been talking about have been essentially system-level interventions that we probably could have done 10 years ago or 20 years ago, IT is really potentially qualitatively changing the game. So, we're doing some work now, both on the patient side and then on the provider side, in terms of trying to use IT as a tool to improve care. One of these is a concept which is very central to this sort of crosswalk between data and practice, which is the idea of a registry. Really simple idea, but one that just, I don't know, no one has really done until fairly recently. All a registry is, has a list of all who the patients are, who you're treating. You pick your key outcomes, right? So for depression, this has probably been used the most. Might use the PHQ-9. And then for medical problems, it's just a list of most important issues. This is one from the home study, which is just has blood pressure, blood glucose, hemoglobin A1C, and weight. And then we just have little red squares for people who aren't at target. We have treatment rounds every 2 weeks, and what we talk about are patients who are still red. And it's all about saying, what's being done so far. If a new medication was just started or a new program was just begun, that's fine. We'll check again in another couple of weeks. But if we can help, but if the patient isn't getting better, then we try to drill down on that. Are they on the right medication? Are they taking their medication? If they're not taking the medication, what's the problem? Are they able to afford the medication? Are they having side effects? So we're trying to use this, but this is really, although this is an approach that's being used now in a lot of research studies as well in this area, it's really also just a very basic quality improvement approach that really everyone should be using. Second, we've been hearing a lot about electronic health records. One challenge with electronic health records for patients with serious mental illness is that they tend to be based in one organization, whereas people, particularly the populations that we're working with, tend to move across multiple different organizations. They get their medical care one place, their mental health care another place, their substance use care a third place. So we thought, okay, what if we made this patient-centered and we had the patients kind of own the data through a personal health record. We did a study of this funded by ARC, one of actually the few mental health studies that they've funded, and again found a real significant improvement in terms of their receipt of preventive services that they received. And now we're kind of trying to catch up with the rest of the world and go from what was the best technology in 2007 or something when we applied for that first grant, which was web-based, and to go mobile. We're doing a couple of projects in that area. One is a diet app, which is a game. It's like Angry Birds, a casual game where you're a waiter in a restaurant trying to serve the healthiest food to your customers. You have to pick the healthiest food. If you don't, or you take too long, the customer gets annoyed and walks out. We're working on this with Georgia Tech, and again, I think there's real opportunities here for partnerships with places like engineering schools where they're really kind of on the cutting edge of these new technologies. And then we're also trying to take the concept of the personal health record and go mobile with that as well. And we were recently just funded for a study that will be using a mobile personal health record as a tool to help patients become more activated and improve the quality of care that they receive. And then finally, there's another project. This one, it's not specifically about integration, but it is about data. And it's about partnerships between researchers and the producers of data and the users of data. This is a project that we're doing with the South Carolina Department of Mental Health around a very innovative telepsychiatry program that they implemented in 2009. And it was, again, one of these serendipitous cases where we were sort of in the right place in the right time to get funding to do a really good evaluation of that. And then also, the importance of having good data infrastructure in place to be able to capitalize on those opportunities. So South Carolina has a unique data warehouse that pools data from multiple different sources. So, I mean, sort of the usual suspects, Medicaid, and an all-payer data set and the state, but also other less usual ones. The free clinics, food stamps, social service agencies, and they have the ability to pull on this data so that when we're evaluating this telepsychiatry program, we'll be able to look at the impact not only on health service use, but also the ripple effects more broadly on the health system. And again, I think this is, the opportunity and the challenge that we need to be thinking about in coming years is as we start looking at whole, across people at the service use, the services that they're using, we need to be able to do this and track people across the different service sectors where they're using care. So I just want to kind of end with a little plug. We were just recently approved at Emory to develop a center specifically around this issue called the Center for Behavioral Health Policy Studies, which will really be looking to use this public health perspective to try to bridge the gap between research and practice for people with mental health and substance use disorders, and also to begin to train the next generation of students and junior researchers who will be able to bridge that gap. So I want to just end by saying, researchers, I was very interested when I first came, to Emory in this idea of evidence-based practice, and the researchers love this idea because we're the ones who get to generate the evidence, so we really like that. And I would say that, 10 years of kind of, trying to get out there and do this has made me realize that it really has to be a two-way street, and that this concept of practice-based evidence, where we are looking at natural experiments that are happening in the community, providing rigorous evaluations of those evaluations, and in which, which is more like, less like a kind of one-way kind of researcher with a bullhorn kind of yelling in the ears of practitioners and saying, adopt my practices, is something more like a dialogue in which iteratively over time you're able to identify questions between producers of the data and the users of the data, and then come up with answers that will actually be used. So, thank you.